Well, my name is Naifa Busaidy, and I'm one of the endocrinologists at MD Anderson Cancer Center in Houston, Texas, and take care of people with thyroid cancer. So, I always start by telling my patients that thyroid, the thyroid's a butterfly-shaped gland that sits in the neck, and its job is to control the energy or metabolism of the body. And those cells that make thyroid hormone are called follicular cells. And if they become cancerous, they can be either papillary or follicular thyroid cancer. Rarely would they be something called anaplastic. And papillary and follicular cancer is just the way it's shaped or looks under a microscope. And together, those two are called differentiated thyroid cancer. So when the patient, and that's been a swinging pendulum, what treatment actually is. It used to be that it was always a three-pronged treatment, meaning patients would have surgery, have their thyroid removed, and any abnormal lymph nodes that were involved with cancer, followed by something called radioactive iodine, and then followed by thyroid hormone, and a little more thyroid hormone than the body needs, called thyroid hormone suppression. And we've realized that we need to personalize the treatment a lot more. And so if patients have smaller tumors, sometimes observation is warranted, or half a thyroid, or what's called a lobectomy, is warranted, in which case neither of those would be followed with radioactive iodine. And sometimes the patient needs an entire thyroid removed with some lymph nodes removed. Radioactive iodine, the pendulum on that has also swung, that it's not automatic just because somebody has papillary follicular thyroid cancer that they receive radioactive iodine. It depends on what their risk is for thyroid cancer. And the new thyroid cancer guidelines that came out in 2015 are much better at outlining who should get radioactive iodine, and let's risk stratify patients. And then thyroid hormone, because if the patient had their thyroid removed, they then need thyroid hormone. But depending on their stage of cancer that they presented with, or if they have cancer left over, how much thyroid hormone they should be on or what their goal TSH is has also changed. So there's several questions that come to mind. So if they were just diagnosed, they need to understand where their thyroid cancer is and has it spread outside the thyroid into lymph nodes. Did they have good imaging, whether it's an ultrasound or a CT scan of the neck, that identified what their thyroid cancer is, and how much of their neck or thyroid is actually involved with that thyroid cancer, because all that information helps plan the next step, which is the treatment, or what should be done, and also get the right treatment the first time so that they're not having multiple surgeries or multiple treatments down the road. It's important that they feel comfortable with their doctor. Usually you start out with an endocrinologist, but you may start out with a surgeon. And if, how much thyroid cancer that physician sees, and do they work in what's called a multidisciplinary team, meaning do they talk to the surgeons? Is there a communication, even though the patient will be seeing multiple people? Is there, sort of a unified voice, and that they want to feel that that doctor's their quarterback, right? So that even if you have to see multiple people, you have one person that you can go to understand the disease and your personal story. So patients should never be in a rush. The important thing is that if a patient has thyroid cancer, now we're talking about papillary and follicular thyroid cancer, not the other types of thyroid cancer, that in general, the vast majority of those thyroid cancers are slow growing, that they have some time to meet various doctors to try to figure it out. And they should ask the questions, right? Is it right for me to do observation? Most patients once they hear the C word or the cancer, they automatically want it out, and they want it yesterday. But they need to look at what's going on in my life. When does a surgeon have time to do this, and the right surgeon have time to do this? So I think shopping around, taking a little time to read, and thinking about when's the right time for me, and what type of surgery is the right type of surgery are all important things that they need to think about. So in general, there's time, and don't rush into something until you're sure it's the right thing to do. So there is a role for what's called a watch and wait approach, but not everybody is a candidate for watch and wait approach. So there's different stages of the thyroid cancer where one can do a watch and wait. It can be from the beginning, before surgery, which is rare. Most patients want to cut it out, but there is the role for some patients for that. And then when a patient has already had, let's say, surgery, radioactive iodine, and thyroid hormone, and thyroid cancer comes back, or some thyroid cancer was left, what's called residual disease, then sometimes we need to step back and say, what's the right treatment for this patient? If it's small volume disease that's not growing and not in a threatening area, maybe I need to watch. I've already had surgery. Maybe I don't need that second surgery right now. I want to have time to see what's the biology of the disease. Is it going to grow in the neck or grow somewhere else? Another group of patients that might be optimal for watch and wait is those who have an elevated cancer marker called the thyroglobulin or thyroglobulin antibody, but one can't find, the physician can't find the disease where it's at. And so especially if it's a low thyroglobulin and there isn't anything on imaging, there may be a role for watch and wait to see what happens over time. Because patients are not harmed by a number, they're not harmed by the thyroglobulin, it's the cancer itself. So looking for what's called structural disease is important. Make sure that you have a good understanding of your cancer. There's nothing better than a patient who owns their disease. And it's really hard, because you're not always given all the information from your healthcare provider. So make sure when you sit down, you have a good understanding of what is the stage of my cancer? What is the risk of me getting into trouble from this cancer? What are the risks and benefits of the treatments that you're offering me, right? What can happen? Because as physicians, we can do harm, and our goal should be first do no harm. So step back and weigh everything out carefully before you jump into anything.